There we go. So again, we are very lucky to be joined today by Dr. Heather McArthur, who's a professor at the Department of Internal Medicine at UT Southwestern Medical Center in Texas, where she holds the prestigious Komen Distinguished Chair in Clinical Breast Cancer Research. She also serves as the clinical director of the breast cancer program at the Harold C. Simmons Comprehensive Cancer Center. Dr. McArthur is a medical oncologist with a clinical practice devoted to breast cancer. Her research is focused on advancing diagnostic and therapeutic strategies, particularly in the realm of novel immunotherapies. She earned her Master of Public Health from Harvard University with a specialization in clinical trial design, and she's mentored numerous medical students, residents, fellows, and junior faculty in research conduct and reporting. She truly is an internationally recognized speaker and leader in breast cancer research. She has held key positions, including co-chair of the Breast International Group Immunotherapy Task Force and membership on the NCI Breast Cancer Immuno-Oncology Task Force, the Alliance for Clinical Trials in Oncology, IO Working Group, and scientific committees for ASCO, SABCS, and ESMO Breast. Dr. McArthur currently serves on several global phase 3 study steering committees and is the principal investigator on multiple international trials evaluating therapies for breast cancer. And we're honored to welcome her today. I'm Sonal Gandhi. I'm your moderator today. I'm a medical oncologist here at Sunnybrook Odette, and I'll be pleased to help facilitate some questions and for Dr. McArthur as we go through and towards the end of the presentation. So our objectives for today are to understand the role of hormone receptor status on treatment selection and patient outcomes in metastatic HER2-negative and HER2-low breast cancer, examine the safety and efficacy and clinical application of novel therapies for HER2-negative metastatic breast cancer, and utilize a patient case to refine management approaches for this subgroup of cancer patients. This learning program has been funded by Gilead. We're very grateful for their support in supporting Dr. McArthur to speak with us today. And of course, the opinions expressed in this program are of the faculty and do not necessarily represent the views of Gilead. These are our presenter disclosures, and I'll now hand it over to Dr. McArthur to take us through her presentation. What I'll have you do is please kindly put any questions in the chat and I'll monitor and we'll figure out if we would hold them to the end or maybe go through them during the presentation based on the patient case as it arises. Heather, please.
Thank you, Dr. Gandhi, for that very kind introduction. I'm sorry it didn't work out that I could be there in person, but looking forward to connecting with many of you later in the week at the breast cancer meeting in Toronto. And maybe the most important part of my background is that I did my medical school training at the University of Toronto and my fellowship in my hometown. Actually born in Toronto, but then raised in Vancouver and did my fellowship at the BC Cancer Agency. So always a pleasure to be reconnected with my Canadian roots. Awesome. Okay. So I don't need to tell this crowd that breast cancer is the most common malignancy among females in the United States, so in Canada and in the United States. So in the United States this year, more than 300,000 new breast cancer diagnoses and more than 50,000 breast cancer deaths, and very similar numbers in Canada. 25.6% of new cases in women are breast cancer and 13.4% of deaths due to cancer in Canada are related to breast cancer. So on average, 80 women will be diagnosed with breast cancer and 15 will die of breast cancer every single day. So these numbers are astounding, more than 2 million new diagnoses worldwide each year, with 1 in 7 or 1 in 8 women affected. So obviously the burden of this disease is tremendous globally, not just in North America, but globally. I don't know if I'm controlling the slides or not. Jessica, I don't seem to be in control.
It just says waiting. Oh, I think it says you're controlling it. Is it moving?
There we go. Okay, perfect. Thank you. And as you all know, each clinical subtype has a unique set of characteristics, and these clinical subtypes are becoming increasingly complex as we delve into the HER2 low and HER2 ultra low. But here you see conventional characteristics. Of course, hormone receptor positive HER2 negative breast cancer comprises about 70% of our breast cancer population. Only 9% of patients have hormone receptor positive, HER2 positive, or triple positive disease. Triple negative breast cancer represents about 10 to 15% of breast cancer, and that rare hormone receptor negative HER2 positive population is only 4%. But they have very variable natural histories. You can see very variable BRCA mutation prevalence, highest in the triple negative population by incidence, but proportional in the hormone receptor positive, and very variable PD-L1 status as it pertains to immune therapy. Sorry, I'm not sure that I do have control, Jessica.
Yeah, it's a little sluggish.
Either on the keyboard or the, okay.
Yeah.
It might be better if you drive, Jessica, because it's just too delayed, if you don't mind.
No problem.
So the cornerstone of therapy, once a patient develops endocrine therapy resistance, are very limited. We've relied heavily on conventional chemotherapy. Of course, if there's one of those rare germline or even somatic BRCA mutations, PARP inhibitors can be very effective. And then targeted therapies in this population, pembrolizumab, for example, for MSI high, and these other much less common approaches for targeted therapy. So in the era of conventional chemotherapy, which has been, again, the cornerstone, we've leaned very heavily recently on antibody drug conjugates, which are novel strategies for developing or administering conventional chemotherapy. Of course, chemotherapy is associated with poor outcomes. Endocrine therapy resistance is associated with poor outcomes, and chemotherapy accordingly is also associated with poor outcomes in that population. Survival has been demonstrated to worsen with each successive line of therapy, and we see this in our clinical practice. They get 6 months and then 4 months and then 3 months with sequential lines of therapy. And of course, this says patients may develop resistance, but they always develop resistance, I would argue, to conventional chemotherapy following successive lines of therapy. PARP inhibitors have demonstrated significant improvement in progression-free survival compared with chemotherapy, but have not conferred an overall survival advantage, but have excellent quality of life. So I guess the bottom line here is that there's an unmet need, given the heavy lean on conventional chemotherapy, for more effective and tolerable treatment options for the majority of patients with hormone receptor positive HER2 negative breast cancer. Next slide. Triple negative breast cancer is a particularly aggressive subtype of breast cancer with limited options. Again, we've relied almost entirely on conventional chemotherapy until recently. And you can see a number of studies here looking at conventional chemotherapy, several studies looking at eribulin, for example, versus platinum-based therapy, all of them associated with a very poor overall survival of only about 4 months, reported as combination therapy for the second line or later, also associated with very poor response rates in the form of 11%, and of course have high rates of toxicity and very poor duration of response. Next line. So how do we address the limitations of conventional cytotoxic chemotherapy? And that's where antibody drug conjugates come into the HER2 negative metastatic breast cancer forecast. So the limitations of cytotoxic chemotherapy, they lack tumor specificity, dose-limiting toxicity via systemic exposure of normal cells to cytotoxic agents is an issue. There's a narrow therapeutic index, and thus antibody drug conjugates were designed to have an expanded therapeutic index and deliver more targeted therapy directly to tumor cells, thereby improving efficacy and mitigating related toxicity. Next slide. And I think it's worthwhile to remind ourselves what the history of antibody drug conjugates are. It's not a particularly novel idea. More than 100 years ago, Paul Ehrlich described targeted therapy comparable to our modern idea of antibody drug conjugates. And worth noting that 100 years later, the first FDA approval for a targeted Antibody drug conjugate was actually TDM1 for the treatment of breast cancer. So actually breast cancer was the first to the modern ADC arena. And you can see in the bottom box there that we've had innumerable more recent FDA and health authority approvals in recent years for TDM1, TDXD, and other agents across multiple tumor types. Next slide. So antibody drug conjugates have three key components. Obviously, the antibody to the antigen of interest, and that's what allows for tumor-targeted delivery of drug. Then there's the linker, which connects the antibody to the payload. The payload, most of the ones that we're going to talk about today are topoisomerase 1 inhibitors. They exert cytotoxic effects directly on tumor cells, and they are linked through the linker, and it's really the linker technology that is most likely distinguishing one antibody drug conjugate from another. So we're going to see a lot of data supporting ADCs with a similar target, with a similar payload, but it's the linker technology that I think will really differentiate these agents going forward. But they are holistically designed to improve efficacy and minimize toxicity. So how do they work? So innovative mechanism of action, very precise targeting. Again, antibody binds to antigen. It gets taken into the cell, into a endosome, and then the linker is cleaved at that point, releasing the payload, which can cause local cell damage, DNA defects, and then the payload is released either through efflux mechanisms or through direct penetration to neighboring cells, and that's what allows for this so-called bystander effect, which overcomes the clinical challenge of heterogeneity. So today we're going to focus on two different targets. We're going to focus on TROP2, so sacituzumab govitecan and datopotamab deruxtecan are two antibody drug conjugates, and then there's sacituzumab deruxtecan, which we'll talk about a little bit today as well, which is also a TROP2 directed antibody drug conjugate. And then, of course, you're all familiar with trastuzumab deruxtecan, a HER2 directed antibody drug conjugate. But you can see from this schematic that there are a number of other very promising targets. And I think we'll see a lot of very exciting drug development targeting non-TROP2 and HER2 directed antibody drug conjugate, or antigens rather. But currently, these are the antibody drug conjugates that we have available in our current arsenal for the treatment of breast cancer. Next slide. So these are the three drugs that we're going to focus on today. Again, sacituzumab govitecan, datopotamab or Dato DXD, and trastuzumab deruxtecan or TDXD. Sacituzumab govitecan and datopotamab deruxtecan are both TROP2 directed antibody drug conjugates. They both, actually all three of them, have topo1 inhibitor payloads. You can see drug antibody ratios are listed here. I think there's a lot in my mind of hand waving around drug antibody ratios. I haven't seen a correlation in my mind between drug antibody ratios and efficacy overall, but I think the bottom line point of high DARs here is that you are delivering more drug directly to tumor cells and hopefully mitigating any off-target toxicity. They all have bystander effect, all three of them, and are all currently approved by health authorities. Next slide. So TROP2 made sense as a therapeutic target because it's broadly expressed and allows for selective delivery of potent agents. It's a pan-epithelial cancer antigen that is overexpressed in all breast cancer subtypes, and that's what you see here. It's present in hormone receptor positive, HER2 negative, triple negative, et cetera. So overexpressed in all breast cancer subtypes and about 80% in triple negative breast cancer. Expression is much lower in normal tissues, which makes it an ideal target for antibody drug conjugate. It's a marker, TROP2 is a marker of poor prognosis, is associated with larger tumor size and higher risk of recurrence. And high TROP2 levels are associated with a more aggressive phenotype as well as resistance to chemotherapy. So first we'll focus on sacituzumab govitecan. So that was the first in class TROP2 directed antibody drug conjugate. As previously stated, the antibody is directed to TROP2. It has a unique linker for SN38 with a high drug to antibody ratio, 7.6 to 1, a pH-sensitive linker that allows for rapid release of the payload at or inside the tumor, and has an SN38 payload similar to irinotecan or a derivative of irinotecan. And this unique technology allows for a bystander effect in an acidic tumor microenvironment. The SN38 is released from the TROP2 antibody and diffuses into neighboring TROP2 negative cells or is removed from the cell through efflux mechanisms. Next slide. So ASCENT was the first phase 3 study of sacituzumab govitecan. It was evaluated in relapsed or refractory metastatic triple-negative breast cancer using conventional ASCO-CAP definitions for triple-negative disease. This was a heavily pretreated population who received at least 2 prior lines of chemotherapy for unresectable or locally advanced or metastatic disease. One of the required prior regimens could be from progression that occurred within a 12-month period after completion of neoadjuvant therapy. So again, a high-risk population, and patients with stable brain metastasis were eligible. Just over 500 patients were randomized 1-to-1 to receive conventional chemotherapy in the form of capecitabine, vinorelbine, gemcitabine, or eribulin versus sacituzumab govitecan. Notably, sacituzumab govitecan is administered at 10 milligrams per kilogram intravenously on days 1 and 8 of every 21-day cycle. And I just underscore that dose and schedule because it pertains to some of the toxicity issues that we'll discuss later on in the program. The primary endpoint for the study was progression-free survival by BICR. There were a number of stratification factors, number of prior chemotherapy, 2 or 3 versus more, geographic region, and presence or absence of known brain metastasis. Next slide. And here's the bottom line. Sacituzumab govitecan demonstrated statistically significant and clinically meaningful improvement in progression-free survival and overall survival. So in the bottom 2 Kaplan-Meier curves, you have the intention to treat population, which includes patients with brain metastasis. And in the top 2 Kaplan-Meier curves, you have the primary study population, those patients who do not have brain metastasis. And you can see in those top 2 Kaplan-Meiers that sacituzumab govitecan outperformed conventional chemotherapy with an improvement in progression-free survival. So a devastating 1.7-month progression-free survival in the conventional chemotherapy population, again, underscoring what a devastating prognosis is conferred here in triple-negative disease that's heavily pretreated. So improved from 1.7 to 5.6 months with an impressive hazard ratio of 0.41. And that progression-free survival advantage translated into an overall survival advantage with essentially a doubling in overall survival from 6.7 to 12.1 months. And when you look at the intention to treat population that included patients with brain metastases, smaller number, those are the patients represented in the bottom 2 Kaplan-Meier curves, you see very similar improvement in progression-free survival and overall survival, including in that incredibly high-risk, poor prognosis population. Next slide. Very consistent benefits in favor of sacituzumab govitecan, regardless of the chemotherapeutic against which it was evaluated. So here, sacituzumab govitecan is illustrated in blue in the progression-free survival on the left and overall survival on the right. And the individual chemotherapeutics, whether it be eribulin, vinorelbine, capecitabine, or gemcitabine, are illustrated in the other non-blue colors. And you can see there that sacituzumab govitecan consistently outperformed all of those single-agent conventional cytotoxics. Next slide. And so what's the cost of innovation? So very notable improvement in PFS and OS. What's the cost, not just financial, but in terms of toxicity? Well, neutropenia and diarrhea are probably the most clinically notable side effects, and we'll talk about these a little bit later on in the program. 63% rate of neutropenia, with more than 50% of that being grade 3 or higher in the sacituzumab govitecan arm. And so we've developed strategies to anticipate neutropenia and prevent neutropenia, and interested to hear what's being done currently in Canada. Diarrhea, almost 60% of patients experience diarrhea, although only 10% is grade 3 or higher. So very manageable. So you can see here the different rates of neutropenia in that box at the bottom: 51% versus 33%, diarrhea 10% versus less than 1%, leukopenia 10% versus 5%, and anemia 8% versus 5%, low rates of febrile neutropenia. GCSF was used in 49% of the experimental arm versus 23% in the physician's choice arm. And interestingly, dose reductions due to treatment-related adverse events were very similar across the arms. There was no severe cardiac toxicity, no treatment-related deaths in the experimental arm, and again, adverse events leading to treatment discontinuation were very low for both the experimental and the control arms. Next slide. In a post hoc analysis of time to onset and duration of key adverse events, you can see here the median time to onset and duration of grade 3 or higher treatment-related adverse events. So looking at the top box, which is neutropenia, median time to onset for the first event was 20 days, any grade 13 days. For physician's choice chemotherapy for grade 3 or higher, very similar, 21 days. Short duration, however, neutropenia, 7 days for any grade and 6 days for grade 3 or higher. Discontinuation, again, related to neutropenia, was low, was non-existent for sacituzumab govitecan versus 1% for physician's choice chemotherapy. And with respect to the diarrhea, so discontinuation due to adverse event, and sorry, I should mention that the time to onset for first event for diarrhea was 12 days, any grade, 19 days grade 3 or higher, with short duration, 5 days, any grade for diarrhea. And discontinuations due to diarrhea were non-existent in both the experimental and control arm. I feel like this is a toxicity issue that we're very comfortable managing in our clinical practice with this and other agents. Next slide. So that leads us to the most recent presentation that we just saw at ASCO a couple of weeks ago. That's the ASCENT-04 Keynote D19 study. This is a study that enrolled patients with newly diagnosed unresectable or metastatic triple-negative breast cancer, so they hadn't received any palliative therapy to date. They had to have PD-L1 positive tumors using the combined positive score greater than or equal to 10 that we use to inform treatment about pembrolizumab in the first-line triple-negative setting. And they had to be at least 6 months since treatment in the curative intent setting. Notably, prior anti-PD-1 or PD-L1 directed therapy was permitted, although we'll see in a minute that represented a small minority of patients participating in the study. So this is basically going head-to-head against Keynote 355, and you can see all of the chemotherapy options here representing the 355 experience, going head-to-head against the experimental arm of sacituzumab govitecan with pembrolizumab. Again, sacituzumab administered at standard doses, 10 milligrams per kilogram, day 1 and 8 of every 21-day cycle. The primary endpoint was PFS by BICR. There were a few stratification factors: de novo versus recurrent disease, geography, and prior PD-L1 or PD-1 exposure. Next slide. So here you can see the baseline characteristics for patients on ASCENT-04. Mostly a white population, about 40% of patients representing the US, Canada, and Western Europe. Good performance status, about a third of patients having de novo metastatic disease. And you can see the distribution of metastatic sites on the right. Over half of patients had taxane-based therapy. And what's notable here, I think, is the last line on the right part of this table. prior anti-PD-1 or PD-L1 therapy, only about 4 to 5%. So this is not representative of your Keynote 522 progressing population. That's not what's captured here. So unmet need still in understanding how best to treat that population, and it's not been determined yet whether continued checkpoint inhibitor therapy after progression with a change in the chemotherapy backbone is an appropriate strategy for that population. And this study doesn't ask and answer that question. Next slide. So here you see the progression-free survival by BICR on top and investigator assessment on the bottom. And you can see a notable improvement. This is a very poor prognosis population. So chemotherapy and pembrolizumab, median PFS 7.8 months. Historically, this is a population who, before Keynote 355, had a life expectancy of 12 to 18 months. That was pushed up to about 24 months with Keynote 355. So to see an improvement of this magnitude on top of or beyond Keynote 355 is really unprecedented and worth just reminding ourselves of the prognosis of this specific population. So improvement in PFS by BICR, 7.8 to 11.2 months, very similar improvement by investigator assessment. So the combination demonstrates statistically significant and clinically meaningful improvement in PFS when compared with chemotherapy and pembrolizumab, with a 35% reduction in risk of disease progression or death, as evidenced by that hazard ratio of 0.65. So very consistent benefits seen here, again, both by BICR and investigator assessment. Next slide. Overall survival data were immature at the time of the ASCO meeting, maturity rate only about 26%. However, it did appear that there was a translation of that PFS benefit potentially into a future OS benefit with a trend in favor of sacituzumab govitecan. 81% of patients who received any subsequent treatment after discontinuation of chemo and pembro received sacituzumab govitecan. So that's a notable crossover because it is a standard of care in subsequent lines, and so important that patients had access. So whether that will ultimately undermine the overall survival curves has yet to be seen. It could very well because of this downstream access to sacituzumab govitecan. But it does seem that there might be some survival advantage. And that wouldn't surprise me because whenever we use our best strategies earlier on in the course of disease, we seem to derive more benefit. So more to come as that data further matures. Here's tumor response and duration of response by BICR. So higher objective response rate in the sacituzumab govitecan arm, 60% versus 53%. Most of those being partial responses, and you can see duration of response in the right-hand Kaplan-Meier curve. In my mind, an impressive improvement in duration of response from 9.2 to 16.5 months. So a substantially longer duration of response and higher overall response rate were observed, including complete response rate, although again, the majority of the responses were partial response, but the delta was most notable in the complete response group, again, in favor of the sacituzumab govitecan pembrolizumab combination. Again, what's the cost? Not just financial, but toxicity. So here you see the exposure and safety summary. Median duration of treatment was very similar across for both sacituzumab and pembrolizumab, rather. They were not as long, not surprising, because you've seen that PFS curve in the chemo, for chemo versus pembrolizumab. So those sort of went hand in hand, the pembrolizumab with the chemotherapy, whether the chemotherapy was conventional or ADC. Treatment-related adverse events, so grade 3 or higher, very similar across the populations. Lower adverse events leading to treatment discontinuation in the sacituzumab govitecan arm, so 12% versus 31%. Similar rates of dose interruption, but fewer dose reductions, and very few, thank goodness, events leading to death. So despite the longer duration of treatment, about 2 months longer with sacituzumab govitecan with pembro, the rates of grade 3 or higher adverse events were very similar for both groups, with treatment-related adverse events leading to dose reduction or discontinuation being lower in the experimental arm. Next slide. The adverse events identified were very consistent with those that we've seen in other studies and aligned with the known profiles of both sacituzumab govitecan and pembrolizumab. So no new safety concerns were observed, and no increased rates of adverse events of special interest were observed with the combination, not surprisingly. So the majority of events being related to the chemotherapy backbone, whether it be conventional chemotherapy or sacituzumab govitecan, and very few immune-related adverse events. Again, very much aligned with what we saw, for example, in Keynote 355. All right, so that was our first foray into antibody-drug conjugate sacituzumab govitecan for triple-negative disease. Thereafter, we saw a study looking at the same asset, this time as single agent, going head-to-head against physician's choice chemotherapy in the TROPiCS-02 phase 3 study. This was a study looking at the ADC versus physician's choice in metastatic hormone receptor positive HER2 negative breast cancer. Patients to qualify had to have received at least one line of endocrine therapy. They had to have received CDK4/6 inhibitor therapy and a taxane in any setting. They could receive 2 to 4 lines of chemotherapy for metastatic disease, so a potentially very heavily pretreated population, and we'll see that in a minute that it was a very heavily pretreated population. There were a number of stratifications based on visceral disease, endocrine therapy, in the metastatic setting or prior lines of chemotherapy, 2 versus 3 or 4, and primary endpoint PFS by BICR. Next slide. And here you can see the progression-free survival and overall survival. So on the surface, in my mind, the progression-free survival, the delta is not overly impressive. So it improved from 4 months to 5.5 months. So a 1.5 month delta in progression-free survival, which again, on the surface wasn't compelling to me. But when you look at the landmark analyses at 6, 12, and 18 months, you see notable more than 15-month improvements in progression-free survival. And those improvements did translate into overall survival. So respectively, 35% and 21% reduction in risk of progression or death, with a higher proportion of patients being progression-free at each landmark. So I'll be curious to hear what your interpretation of the data was. But again, that delta of 1.5 months wouldn't have been enough to change my practice the next day. It was really these landmark analyses that informed my current standard of care. Next slide. And here's the safety summary. So on the left, you have overall response rate. Median duration of response was longer in favor of sacituzumab govitecan, 8.1 months versus 5.6 for conventional chemotherapy. And you can see the responses there. In terms of safety, very consistent safety profile with what we saw in ASCENT, with the primary concerns or clinical concerns being neutropenia or diarrhea. Over 50% of patients had grade 3 or higher neutropenia, and 10% of patients had grade 3 or higher diarrhea, but very consistent side effect profile compared with the preceding trials of this agent as monotherapy. Next slide. Now, how should we think about sacituzumab govitecan in a modern era? We're going to touch on the trastuzumab deruxtecan in the HER2 low and HER2 ultra low. Obviously, there's some tension around which asset do we use earlier on in the course of disease. Should we use trastuzumab deruxtecan versus sacituzumab govitecan? And so the TROPiCS-02 team provided this post hoc analysis looking at sacituzumab govitecan versus chemotherapy in the HER2 low, the HER2 IHC 0, so that potential ultra low population, and the intention to treat population, And you see very consistent benefits across all of these subgroups interrogated. Again, it's a post hoc analysis, so it wasn't a pre-specified analysis, but very similar benefits across all subgroups, which is reassuring in my mind. Next slide. So that brings us to the latest kid on the block, datopotamab deruxtecan. So this is another TROP2 directed antibody drug conjugate. It also has a topo1 payload. It has a unique linker. It has a DAR of about 4 and stable linker payload, and it does have that so-called bystander effect. Next slide. So preliminary data, so we saw the PAN-Tumor01 study, which included a hormone receptor positive HER2 negative cohort, heavily pretreated disease. And with this agent, saw an impressive overall response rate, 27%. And you can see from the spider plot here, really horizontal lines indicating very durable responses in this population. So I thought an impressive data set in a very heavily pretreated population, and so in my mind justified moving this agent forward earlier on in the course of disease. Next slide. And that brought us to TROPION-Breast01. This enrolls patients with hormone receptor positive, HER2 negative breast cancer who had 1 to 2 lines of chemotherapy, so a little bit earlier on in the course of endocrine therapy resistant palliative chemotherapy approach, who experienced progression on endocrine therapy and for whom endocrine therapy was no longer suitable. Patients got randomized to receive investigator's choice chemotherapy, very standard choices there, including capecitabine versus Dato-DXd, with primary endpoints, dual primary endpoints of PFS and OS. Next slide. So here you see the PFS data on the left. So just over 2 months, a 2.4 month improvement in PFS with a hazard ratio of 0.64, with a notable difference in time to subsequent therapy, 5 versus 8.2 months. Next slide. So that did lead to, in the United States, an FDA approval of this agent for the treatment of advanced hormone receptor positive HER2 negative breast cancer. But notably, they're doing these ESMO virtual plenary sessions at somewhat random points during the year. And there was one early in 2025 where they provided the updated data from the TROPION-Breast01, the survival data specifically. And there was no difference in survival, so that PFS improvement did not translate into an OS improvement for Dato-DXd. However, notably, there was a huge discrepancy in terms of access to antibody drug conjugates after patients came off study. So a lot more of the patients who were treated in the control arm had access to ADCs after they came off study when compared to patients who were treated with Dato-DXd. So an imbalance there that makes overall survival a little bit difficult to interpret in this setting. Next slide. So treatment-related adverse events in at least 15% of patients. So nausea, mostly lower grade nausea is an issue with this agent. Stomatitis is a notable side effect with this agent. So patients are advised to use steroid mouthwash where it's available. So not all parts of the world have access to dexamethasone mouthwash, but if you do have access, it's recommended that you use the mouthwash 4 times a day. And it's not a swish and expectorate. You actually have to hold it in your mouth for 1 to 2 minutes before expectorating. And that's critically important because once the stomatitis occurs, it really requires management throughout the exposure to the agent. Alopecia, difficult to evaluate in this setting of heavily pretreated disease. And there is an issue with dry eye on this study as well. So patients are advised to use eye drops 4 times a day. So I usually recommend that people use the eye drops and the steroid mouthwash together 4 times a day. But overall, a very well-tolerated medication. And next, we have the adverse events of special interest because, of course, Interstitial lung disease is of interest with this class of drugs. So you can see here what I talked about on the left, which is the oral mucositis stomatitis. Just over half of patients have some form of stomatitis, and it's very painful. It's not necessarily mouth sores, it's not mucositis necessarily, but it's very painful mouth, which has quality of life implications. So starting at day 1, we recommend that steroid mouthwash. The ocular events, we do a baseline ophthalmology exam, and then again, we advise patients to use those eye drops 4 times a day. And interstitial lung disease. So interstitial lung disease is relatively uncommon with Dato-DXd, so 0.3% fatal ILD events, so lower than what we've seen with other agents. It's actually worth pointing out that there is no ILD with sacituzumab govitecan. There's a misconception that it's a class effect, pneumonitis and ILD, but it actually hasn't been reported with sacituzumab govitecan, and the incidence with these other assets is very variable. So very low with this agent here. Next slide. And so now we'll move on to something completely different. We're going to attend to the HER2 low and the HER2 ultra low space. So HER2 is physiologically expressed on cell membranes of nearly all normal tissues in the body. All breast cancers exhibit some degree of HER2 expression. The detectability depends on the type of tissue analyzed, whether it's paraffin embedded or fresh frozen, and the sensitivity of the assay used. Next slide. And HER2 IHC testing was designed to look for positivity. It was not designed to look for degrees of negativity or low expression, and that's one of the major limits of HER2 testing in this new space of HER2 low and HER2 ultra low. So about 60 to 65% of patients have HER2 low disease in Destiny Breast 04, which we'll show you in a minute. The majority of patients represented have hormone receptor positive HER2 negative HER2 low disease, although there is a small subset of triple negative breast cancer that also has HER2 low disease. And the HER2 low just uses the conventional ASCO-CAP definitions of IHC 2+-ish negative or IHC 1+. And then there's this new category that was created by, in essence, the Destiny Breast 06 experience looking at ultra low. So IHC 0 does not mean the complete absence of staining. To get an IHC 1+ designation, you need to have 10%, greater than 10% of cells staining for HER2. So you can have 1 to 9% of cells staining for HER2 and not meet that IHC 1+ designation, but it doesn't mean that there's a complete absence of HER2 expression. And that's why this category, this IHC 0 category, is very tricky, and a lot of work being done to better understand how to tease out the subsets of that population. It'll be interesting to see how ASCO-CAP actually attends to this space in their next guideline iteration. Next slide. So there have been a lot of studies conducted to evaluate the prognostic role of HER2 low expression, which again, since some of the tests that we use are really designed for that purpose, difficult to know how to interpret this data, but no survival difference in HER2 low versus HER2 0, regardless of expression. Next slide. So Destiny Breast 04, this was presented by a fellow Canadian 3 years ago, Shanu Modi, in the plenary session at ASCO. She got a standing ovation for this presentation. It enrolled patients with HER2 low breast cancer. If they had hormone receptor positive breast cancer, they had to be considered endocrine refractory. Patients were randomized to receive T-DXd versus physician's choice chemotherapy in a 2-to-1 randomization. And as I mentioned here, the vast majority of patients had hormone receptor positive disease. Only about 10% of patients had quote unquote triple negative disease. But it speaks to this new intersection across conventional subtype definitions. Primary endpoint for this study was PFS. Next slide. And here you see on the left that primary endpoint PFS, a 4.7-month improvement, so an almost doubling in progression-free survival with a notable hazard ratio of 0.51 in favor of TDXD, and that PFS advantage translated into an overall survival advantage. This was a secondary endpoint with a 6.4-month improvement in overall survival and became a standard of care soon thereafter. Next slide. What if we hone in on those triple negative patients specifically? Again, it's only about 10% of the population, but you see very consistent benefits in terms of progression-free survival, a delta of 5.6 months, and that translated again into a survival delta of 9.9 months in that subset. And here's the safety summary. So the median treatment duration, TDXD, 8.2 months versus 3.5 months with physician's choice chemotherapy. The most common treatment-related adverse event associated with treatment discontinuation was ILD pneumonitis in 8.2% of patients on the experimental arm, neuropathy in the conventional chemotherapy arm, dose reduction due to nausea and fatigue in 4.6% of TDXD, notably higher rate of dose reduction in the physician's choice chemotherapy arm due to neutropenia, and total on-treatment deaths were similar across both arms. The nausea and neutropenia with TDXD are real. Again, I inherited a patient from Shanu Modi who was on Destiny Breast 01, who was on TDXD for 7 years and had 0 side effects. And we always debated, she had HER2 positive disease, and we always debated about whether to transition her to conventional HER2 antibody maintenance therapy. And because she had no side effects, we ultimately continued her TDXD off study for almost 7 years until she relapsed. And then I had a patient who I treated with 2 doses of TDXD, and her nausea and vomiting, despite optimal prophylaxis, was so horrendous. She said, I don't care if this is life-extending therapy. I never want to see that drug ever again. Most people fall in the middle of those experiences. Those are 2 very, very extreme experiences, but the nausea is real, and you need a minimum of 3 and sometimes up to 4 prophylactic antiemetic medications for patients. The ILD pneumonitis, so this is Destiny Breast 04, despite the intensive surveillance. So here they were looking for pneumonitis every 6 weeks on study and in subsequent studies. And despite the vigilance and intensive surveillance, still had a high rate, in my mind, of fatal ILD, 3 cases, 0.8%. No fatal or, in my mind, clinically meaningful impact on ventricular function. Next slide. So this led to Destiny Breast 06. This was dedicated to hormone receptor positive breast cancer that had HER2 low or HER2 ultra low disease, the minority being HER2 ultra low, heavily pretreated population earlier on in the course of disease. So they had to have had 1 prior line of therapy for metastatic disease and had to have progressed on CDK4/6 inhibitor, TDXD versus physician's choice chemotherapy, primary endpoint, progression-free survival. Next slide. And here you see a very consistent benefit in that lower definition of HER2 positivity with a 5.1-month improvement in progression-free survival. So statistically significant and clinically meaningful improvement in that space. Next slide. And this is in the HER2 low and intention to treat populations, including both the HER2 low and HER2 ultra low. No convincing survival advantage observed here, although there were some differences in post-treatment drug exposure that could account for the differences in survival when compared with progression-free survival. Next slide. And in the ultra-low population, you do see an improvement in PFS that's similar to what was seen in the intention to treat population, 4.9 months. And that did translate into an overall survival advantage. So very consistent with the intention to treat population and led to an approval by the FDA as a result in this population. Next slide. Here's patients with ultra-low disease. Again, you see the Kaplan-Meier we just showed you on the left, and responses favoring complete response and partial response in both the ultra-low and the low populations. Next slide. No new safety signals identified, so very consistent with the preceding studies. Although, again, I would point out that despite the vigilant monitoring with Q6 weekly scans to look for early ILD and pneumonitis, there was still 3 cases of grade 5 or fatal ILD or pneumonitis in this study population. Next slide. Okay, so that was a whirlwind tour of ADCs for hormone receptor positive HER2 negative disease. What drugs should we be using first if there's an intersection, next slide, between TROP2 directed and HER2 directed antibody drug conjugates? So there are some prospective studies ongoing. We have limited retrospective data. This one is from Laura Hubert from UCSF. She looked at sequencing of sacituzumab govitecan to T-DXd and vice versa in hormone receptor positive versus hormone receptor negative disease. And on the next slide, you can see the results of that data. So it's not straightforward. The bottom line in my mind is put your best foot forward, because patients are more likely to have a better response to their first-line therapy than their second-line therapy, and that's what this data set shows. However, that being said, there are a number of patients, and there are some X's here. So if you look at that SG to T-DXd curve on the left, you can see there are some patients who didn't respond to sacituzumab govitecan at all, who had excellent responses to trastuzumab deruxtecan thereafter. So the actual rules for sequencing still remain unclear, and so prospective data is desperately needed. Next slide. Next slide. So these are 2 studies that are ongoing, trying to ask and answer those exact questions. These are studies that are led by the TBCRC cooperative group. There's the TRADE-DXd study that's being led by Dr. Garrido Castro of Dana-Farber, looking at T-DXd versus Dato-DXd and hormone receptor positive versus hormone receptor negative breast cancer, looking at sequencing. And then there's the ENCORE study also being led. It's a prospective registry of sequential ADCs in hormone receptor negative breast cancer, looking as well at sequencing to try and get more prospectively collected data. So that data is highly anticipated. So we will land at a case, if that's okay with you, Dr. Gandhi. So this is a woman who had ER 70%, HER2 2+ by IC-ish negative, stage 2B breast cancer, T2N1, 7 years ago, grade 2, no BRCA mutations, good functional status, mild comorbid conditions, hypertension, osteopenia. And I think we should go on to the next question in the interest of time. Okay, so she gets appropriate upfront surgery followed by dose-dense ACT chemotherapy. She, again, had node-positive disease. She received anastrozole for 5 years. She had 2 years thereafter where she was treatment-free, and then she developed bone and nodal recurrence. She has a biopsy, which should always be done to confirm a diagnosis of metastatic disease. And biomarkers should be recapitulated and genomics interrogated. It's still ER positive, HER2 negative. There's a PIK3CA mutation identified. She goes on standard first-line therapy with an AI and ribociclib, which keeps her disease under control for 18 months. Then she goes on to targeted therapy because of that PIK3CA mutation. She gets capivasertib and fulvestrant, which controls her disease for 6 months, and then is deemed no longer suitable for further lines of endocrine therapy, moves on to chemotherapy in the form of capecitabine, but progresses after 8 months. Now she has disease progression in the liver, and has access to trastuzumab deruxtecan at that point because of the low HER2 expression. However, unfortunately, she develops grade 2 ILD after 18 weeks, despite good disease control. And the question here is, what's the impact of pretreatment history on the patient you see today and future choice of treatment? I know we don't have a ton of time left, Dr. Gandy, but
There was a
Yeah, so first of all, thank you so much, Heather. That was an amazing review of all the data, wealth of data. I think if I could just remind people to go on mute. I think this question is interesting, but also just in general, I'm not sure if anybody has any questions about the approach. And I think, Heather, if I may start, if we have time for one question, maybe I'll take the liberty.
Sure.
Sonali, could I just have you please mute? Let's try and mute her. There we go.
There
Great.
we go.
Thank you. I mean, you've shown that you made a really good case for like the first line therapy, put your best foot forward, and showing everything that you have in terms of how impactful ADCs could be, but also understanding the sort of, what I call the mutational mayhem for these patients who have ER positive disease and develop PIK3, have PI3 kinase mutations or ESR1 mutations.
Yeah.
What do you think our optimal strategy should be in terms of choosing ADCs sooner for some of these patients or not? And particularly for TDXD, Rebecca Dent showed at ASCO this year that patients had some benefit regardless of whether or not they had these mutations as well. So what's your approach in choosing drugs, having a little bit more access to almost everything down there compared to a little bit more?
We do have a lot of drug access here. So in alignment with this case, we would typically exhaust endocrine and targeted therapies before moving on to conventional chemotherapy. So this is a case that's very, representative of a patient I would see in my own clinic. With respect to selection of ADC for patients who are candidates for trastuzumab deruxtecan and sacituzumab govitecan, the NCCN guideline endorses trastuzumab deruxtecan in that space, but I think they're really nuanced shared decisions at this point because, as I pointed out earlier, it's more burden on resources and more burden on the patient because it does require more frequent monitoring, because the goal is to identify grade 1 ILD pneumonitis, so asymptomatic ILD pneumonitis, which can only be detected radiographically, because once it becomes grade 2 or higher, you have to permanently discontinue the drug. Whereas if it's grade 1, there are a handful of cases from some of these data sets showing that you can successfully re-challenge asymptomatic ILD or pneumonitis once it's been appropriately treated. So I can't do scans every 6 weeks in my real world practice like they did on these recent Destiny breast studies. So I do them every 9 weeks. Whereas with any other agent, I typically do scans every 12 weeks. So there has to be buy-in from the patient to go for scans with that regularity. And then patients who I'm worried might be more predisposed, although they've looked at a number of these studies looking at risk factors for developing ILD, and there hasn't been any compelling constellation of risk factors per se. But a patient who had a high lung burden of metastasis might not be my favorite person to put on trastuzumab deruxtecan. Alternatively, someone who struggled with neutropenia on CDK4/6 inhibitors might not be the best patient to go on sacituzumab govitecan, for example, because that's the one thing that I manage most commonly with sacituzumab govitecan. So I think they really are increasingly nuanced conversations, and patient buy-in is critically important.
Absolutely. No, thank you. We're over just by a minute, but we did start a little bit late as we waited for people to log on. I don't know, Heather, if you still have a couple of minutes. This is a really, really rich discussion.
Yeah. I think maybe we could go to the, if you just want to advance a couple slides, I think probably this group is familiar with the provisional funding algorithm in Canada. This slide is just speaking to the fact that, once we see successful strategies in the metastatic setting, we typically move those into the curative intent setting. and that's what's represented here. You have a number of studies looking at ADC-based therapy in the adjuvant setting, particularly for residual triple-negative breast cancer. I'm also the PI for the TROPION-Breast04 study. That's a neoadjuvant study looking at Dato-DXd with durvalumab going head-to-head against KEYNOTE-522. And then Merck just announced a couple of weeks ago their plans for a neoadjuvant study of SAC-TMT with pembrolizumab going head-to-head against 522. And then there's a lot of activity in the metastatic setting as well, including the TroFuse-10 study, which I don't see that listed here, but that's looking in hormone receptor positive first line head-to-head against chemotherapy, as well as the others seen here. So a really hopeful time to be treating breast cancer as we move these strategies earlier on in the course of disease and hopefully further prevent metastatic disease from occurring. And next slide. I think it's also a very exciting time because there are a number of other very promising targets beyond TROP2 and HER2 that are being interrogated. And so I think we're going to see a lot more data in the ADC space beyond just TROP2 and HER2. And just worth noting that there are other strategies looking at bispecific ADCs. So we're looking at one that's VEGF and PD-L1 targeted, dual payloads. So do you need just a topo-1 inhibitor, or what if you combined a topo-1 inhibitor with some other cytotoxic, and other very interesting new mechanisms that are in development? I think that's our last. We have conclusions, but it's obviously a rapidly growing field with an unprecedented pace of drug development, which makes it very exciting, albeit very confusing, because there's a lot of new data coming in fast and furious for us to keep on top of. Thank you for your time today and for including me in the discussion. Thank you.
Thank you so much, Heather. That was fantastic. I don't know if there's any other questions, and if there are, you can feel free to email them to me, and I'm happy to share them. You've got some thank yous in the chat, Heather, and so that was fantastic. So what I'm hearing from you, it's which was beautifully outlined in your talk, is knowing the targets is important and sequencing based on the data, but what the patient needs and wants and the toxicities and the acceptability of the logistics are always top of mind. Now more than ever, as we navigate toxicities and management that we've never done before. And I'm a little bit comforted to hear that you also have issues with getting CT scans every 6 weeks, because for us, that's also been something we've had to really intentionally reevaluate here at our center. So exciting world, but also lots of challenges. Thank you so much again for your time. And I think we're really looking forward to hearing more from you throughout the week as you engage us in various spaces.
Thank you so much. Have a great week, everyone.
Thank you.